Yeah, I think maybe some low value services are delivered because it was convenient to do so. If the machine was right there. And I think from what I've read and heard a little bit, sitting in on webinars and such, is that providers who are in value-based contracts, which have some flavor of capitation, have weathered the storm better maybe than providers that are working, in a fee-for-service world where they saw their service, um, you know, disappear on them. So it does seem like both of those factors may change, as you said, delivery and value models. But
Well, I think that's why we've been so
yeah,
insistent and so aggressive about pursuing value-based arrangements with the systems in our market, because we believe that it will lead to a healthier system that weathers the peaks and valleys. The fact that systems have been addicted to volume means that when volume doesn't come, for one of two reasons, a pandemic or just this community gets healthy,
yeah.
then hospitals have suffered. But in a value-based world, in the partnership that we have with North Memorial and with Alina and a growing number with others, the purpose of that is that those systems can now weather the uncertainties and the shifts in utilization as well as an insurance company has. So that would be the intent and the desire about these types of payment models.
It's interesting. There's sort of a paradox that both a healthy population and a pandemic might play out the same way if you're a provider in a more capitated, value-based model. But
Right.
getting back to my question about how Blue Cross and Blue Shield of Minnesota is doing, where do things stand as far as your MLR, and what are your 2021 rates look like? Um, Now that you're at the end of this tumultuous year, and
Right.
as you described it, a sort of a double peak now.
Right. Well, in a time of double peak, as you can imagine, with a significant rise in utilization, our MLR is not what it was at the beginning of the pandemic. And what I would underscore is that um, we want to invest any favorability that we experience this year in further transformation and further um, um, evolution of the healthcare industry. So we had sort of the lowest utilization rates earlier in the pandemic, and now they're risen to the point where they're comparable to a year ago at this time. So as you can imagine, the MLR in that setting gets eroded. We want to end the year on budget, as was originally designed, because the investments, the favorability that we've experienced either has gone into premium relief, which you talked about earlier. It's gone into racial and health inequities or social determinants of health, or other investments that we can make to avoid an even worsening sick community, or to help resolve the inequities that we've seen in the industry, or it's investing in sort of better telehealth infrastructure or better care delivery infrastructure so that next year premiums don't rise. So we very much expect and are targeting our financial performance to be on par, which is a very low margin because we're nonprofit, for this year as it was last year. We will not be profiting off of a pandemic.
So
The premiums, oh, go
yeah,
ahead.
I'm sorry. You mentioned investing in telehealth. In what way is a Blue Cross Blue Shield plan investing in telehealth? I thought that would fall mainly to providers to do, or perhaps the direct-to-consumer companies. Maybe you have a contract with one of them. I don't know. But are you directly investing in telehealth?
Well, we're not, I'm not signaling that we're acquiring a company in the telehealth space, if that's what you're getting at. Um, a better way for me to describe it is we're investing in models that we believe are going to be more contemporary in primary care delivery. So we had shared before that we've gotten into the care delivery business. I think I had talked to you first about being like Netflix, where we get into content. We very much are doing that because we see a hunger by patients and by consumers in an alternative care delivery model that isn't facility centric. And whether that's telehealth or mobile urgent care or care coordination in the home, those are the things that we're investing in because we believe that they're going to ultimately create a higher value model for patients that we're hungry for. I think we want our industry to be as high performing as other industries. In terms of premiums, I apologize if I can't remember the exact numbers we talked about before, but you remember early in the pandemic, there were some estimates that premiums would rise by as much as 40% in 2021. We are not seeing that at all. In fact, our estimates are in kind of the mid-single digits in terms of the impact on premiums. And I'd love to be able to even see better than that. If we have truly learned from this crisis, which for me means that we reward for value, not volume, that we avoid low value care, and those things don't need to happen, that we invest in what I call the ounce. And I call it the ounce because of the adage, the ounce of prevention is worth a pound of cure. If we invest in the ounce, we invest in prevention, wellness, social determinants of health, racial and health equities. If we truly believe investing in those things, which we are this year, will keep people healthier next year, then you would hope that premiums flatten out. The cost of care goes down because of all those levers you can pull.
Right, right.